Today I'll be discussing the 1918 flu in the United States. So first, let's begin with the origins. So, the Spanish flu has been an enigma for over 100 years in the science community. And this is because it's been quite difficult to track where it began. This is partly because the easy transmissibility of the virus, the United States moving troops across Europe and France during World War I. Another reason for the uncertainty is there had been a previous flu outbreak in China in the early 1918, which many believed was the origin. But all that has been discredited, and the best guess it began in Funston Military Base in Kansas on the 4th of March. It was initially brushed off as a seasonal outbreak or potentially meningitis, and it was not reported to the press until April of 1918. The first wave was caused by an H1N1 variant and had been mutated with avian genes, most likely waterfowl. And it wasn't until the second wave, which mutated in November, just in time for the troops to return home for more, that it became an even more deadly and more transmissible disease. And another reason for that is because it was able to be contracted by both humans and swine, especially in the Midwest, where swine farming was quite normal. And here on the right is a picture of Funston Military Base during 1918. So next, let's talk about how it spread. And on the right, I created a timeline of some important events that happened during the 1918 pandemic. So firstly, I would like to note that H1N1 had previously existed, and it was not until the normal endemic flu season of the United States where the avian gene had mutated. Within 3 weeks of the first initial outbreak in Camp Funston, nearly 2% of the 56,000 troops stationed there were hospitalized, with countless more becoming sick with the disease. By April, the United States saw outbreaks in 24 of 36 of its army camps. This also happened to be when the US entered World War I. With aid already present and with troops preparing to be deployed, the flu spread like wildfire in these camps, as well as Europe, especially France. Within merely a month, many European and Asian countries had seen their first case and even outbreaks in many countries like France and Spain. By July, it had reached the easternmost part of Europe, excluding Russia, and Poland. And by December, it had reached some of the most remote places in the Pacific Ocean. Samoa and New Zealand saw their first cases less than a year after its origin, in December and in November. Next, we will have the deadliness and who was affected. Here you go, Lily.
Thanks, Corbin. So I will be addressing deadliness of the pandemic and who was affected. This pandemic was identified as the most severe in recent history. Estimates indicate that around 500 million people were infected, which was 1/3 of the world's population at the time. There were approximately 50 million deaths across the world and 675,000 in the United States alone. As Corbin mentioned, the pandemic happened in 3 main waves, with the second wave being the deadliest. This photograph from the National Archives was taken during the second wave in October of 1918 and shows an emergency influenza hospital set up outside in Brookline, Massachusetts. Flu and flu-related death rates during this pandemic for people ages 15 to 34 years were 20 times higher than had been previously encountered. Nearly half the flu-related deaths during this pandemic were in that age group. The figure to the right shows a normal flu-related death rate between 1911 and 1917, which is represented by a dotted line. It is a U-shaped curve, with many of the deaths happening in young children and adults older than 65. The solid line depicts flu-related deaths during the 1918 pandemic. It is a W-shaped curve because of the high number of deaths among healthy younger adults. During this pandemic, the risk of death was actually higher for people younger than 65 than it was for people older than 65. And not even just a little bit, people younger than 65 accounted for more than 99% of flu and flu-related deaths in this pandemic. During the second outbreak, as many as 1,500 individuals reported sick per day, and deaths averaged about 100 per day. People who had contracted the illness were dying within 24 to 48 hours, and upon autopsy were found to have many hemorrhages in their lungs. The reason for this is that in young, healthy individuals, the immune system releases certain chemicals to fight microbes in the lungs, and the immune system response to this virus was so strong that it actually caused tissue damage. This explains why the young, healthy age group suffered such a high death toll. Through the pandemic, although the death toll was high, the death rate itself was not that high. In the United States, it was around 2%. MetLife Insurance Company conducted a study of people between the ages of 25 and 45 in the US during this pandemic and found that 3.26% of all industrial workers and 6% of all coal workers died. And I will pass it on to Kobe for the next topic.
All right, thanks, Lily. So I'm now going to be talking about some of the policy responses to the 1918 pandemic. And before jumping in, it's important to note that whereas today many of the COVID-19 policy responses are centered around pharmaceutical development and distribution, in 1918, the pharmaceutical intervention was much less prevalent. So many of these policy responses are non-pharmaceutical in nature. But with that in mind, we'll kind of dive into the first one, which is school closures. And similar to the way that school closures are handled during the coronavirus pandemic, in 1918, closures were decided at a local level. However, in October of 1918, the Surgeon General at the time issued a recommendation for cities to close schools and other businesses, and that was definitely followed by many cities, the first of which, Boston, and many other large cities followed soon after. But there were also many that did not. In fact, some of the cities had trouble closing due to kind of a narrative at the time that the schools were some of the safest and most important places. So many of these pro-school opening arguments kind of made it harder and less prominent in some cities to fully close down schools. And there are a couple of important differences between the COVID-19 pandemic school closures and some of the ones during 1918. For example, schools were closed for significantly less time on average. This kind of one of the main reasons for this being simply that there was not kind of an ability to do remote learning, and there was more of a rush to reopen. And on top of that, whereas COVID-19 kind of targets older demographics, children were much more susceptible to the 1918 pandemic. So that was important to keep in mind. There were a lot of absences despite opening schools. And on top of that, obviously there was much less remote learning. So there's an argument out there presented in Auger et al. That essentially there's less socioeconomic disparity due to the closures, simply due to a lack of remote learning that was depended on during the pandemic. So next I'll kind of discuss mask mandates. And by the fall of 1918, 7 large US cities had established kind of a mandatory face mask law, San Francisco being the most prominent one, due to the severity of their mask mandate, and that was enforceable with fines and also jail time. And it's important to note that similar to the way that COVID-19 has played out, there were also anti-maskers at the time. And there was actually an anti-mask league of San Francisco, kind of an organized anti-mask organization. So similar to the pandemic currently going on, there are some common ways that were also used to deter the pandemic. In 1918, social distancing, basic kind of quarantine that was particularly prominent in kind of port cities, such as New York, and fumigation, things like that. And lastly, kind of public awareness campaigns such as washing your hands, common courtesy of hygiene, things of that nature were definitely really important. And then kind of lastly, I just wanted to do a quick compare and contrast of 2 different policy responses, one of which being St. Louis, which handled it very well, and the other Philadelphia. And so St. Louis very early on in the pandemic kind of took note to limit closures, to initiate closures and limit gatherings to 20 people, whereas Philadelphia took kind of a slower approach and actually had a very large parade early on in the pandemic, which led to a lot of early cases. So as you can kind of see by this graph in the bottom left, Philadelphia had quite higher death rate earlier on than St. Louis, and this is kind of used as a case for flattening the curve in pandemics in the future.
So to wrap us up, I'm going to be talking about the short and long-term impacts from the pandemic and some of the responses following the pandemic. A recent study suggested that MPIs used in the 1918 pandemic reduced mortality and flattened the infection curve. In addition, researchers concluded that in the short run, MPIs didn't exacerbate nor immediately fix the economic downturn. They suggested that the pandemic on its own caused labor shortages and therefore business disruptions in the fall of 1918. And I'll get into that more on the next slide. Using this data, they compared cities that implemented MPIs aggressively and early on versus those who were more lenient and found that business disruptions were about the same, which you can see in the figure to the right, which shows this across various sectors. However, in what they described as the medium run, using data on cities' manufacturing, employment, and output, they found that the cities that had stricter implementation of MPIs did not experience as large of a decline in employment and output, and actually found that they had an increase in economic activity following 1918. This early implementation mitigated the immediate and long-term impact that the pandemic causes on its own, which would put those cities at a stable advantage at the conclusion of the pandemic. And we use the coal industry to describe the impact on labor and production at the time. The coal industry employed around 2.5% of the labor force. So a negative labor supply shock caused by infection and death had an immediate and rapid impact on production output in the coal industry, which is highlighted in the graph to the left. The graph to the right further confirms the positive correlation between excess mortality and the output loss. The x-axis here shows the excess mortality per state, and the y shows the output loss caused by the negative labor supply shock. So like I said in the last slide, though the indirect impact of mortality and infection on labor supply was significant, the direct impact of the closings on economic activity was relatively small. Credit rating agency Dun & Bradstreet collected data on business failures shown in the figure to the left. And it's evident here that there's some impact from mortality, but not any sort of significant downward or upward trend. The same agency also reported on various cities' business conditions across sectors. And the table to the right strongly suggests that business conditions were mostly fair or good, according to self-reports by businesses in these sectors. And this pandemic didn't necessarily have many long-term impacts, but one study suggested that pregnant women exposed to the flu gave birth to children who had medical problems later in life, which brought a lot of economic hardships for them. These children were 15% less likely to graduate high school, and these men ended up having a 5 to 9% lower wages than the rest of the male labor population. And to wrap up, some of the examples of response policies that came after the pandemic were in an effort to address the nursing shortage the pandemic had exposed. Illinois created a one-year practical nursing course. Public health officials also recognized that closely packed urban housing was contributing to the spread of illness and disease. So subsequent legislation addressed this issue, such as in the New Deal. And lastly, other countries, including the US, worked to consolidate healthcare plans. So a group of healthcare workers in Texas created Blue Cross Blue Shield to offer affordable and viable healthcare by 1929. And if anyone has any questions, please use our forum page on Sakai. Thank you. And now I'm just going to tap through some of our works cited.